is on the ventilator. So 2 years ago when I presented a similar topic in Rajkot, thanks to you all, I got to meet the same friends after a while. At that time I had shared a template on how to look at ventilator modes. And what we are seeing now is sort of a follow-up from that talk. And so here what we'll do is, I'll just do a very brief 2-3 minute recap of what we discussed in that session, and then follow up with analysis of the key points you need to identify on a ventilator waveform. The other point that I would like to mention is that this is going to be a continuous process, just like how you are used to looking at, let's say, ECG, where you go stepwise in the ECG, you go look at the ECG rhythm strip, look at the P, Q, R, S and ST segment. There's a sequence to do that. Similarly, you'll find that even in ventilator waveforms, that's a similar methodology you need to adopt.
All delegates and consultants, Google form for reviewing of this conference related to different parameters. Please fill the form and give your feedback. It is shared in ISACON group.
Sorry for the technical difficulties, but we're on track. So this is the aim. What I'd like to talk to you guys about is that there are a lot of templates in ventilator analysis, but this is a recently published one in 2021 as a result of about 20 years work from one of my mentors, and makes it pretty straightforward and easy for you to analyze any abnormality that you see on a ventilator screen, regardless of the manufacturer. There are 3 main steps. One is to tag what is happening on the ventilator. What is the ventilator trying to do? The second step is to analyze the load. There are only 3 loads that are possible on a ventilator. One is resistance, the other is elastance, and then you have PMUS or patient effort. And any abnormality you see on the ventilator can be interpreted based on the load. Once you identify the load, you look at what is the patient-ventilator interaction, also called asynchrony. So, in the previous talk that I gave, we talked about the tag in that, and now I'll focus on this discussion, how to look at the load and the PV relationship. But once you figure out what's going on, the key is that you need to identify what the goals of mechanical ventilation are. And just like you have only 3 types of load, you have 3 goals. One is safety, the other is comfort, and then finally liberation when the patient comes to you in the ICU so that the patient gets off the vent. So, predominantly in the OR, you will be focusing on safety, whether it is carbon dioxide levels, oxygen levels, tidal volume, so on and so forth, other safety metrics. As a recap, this is how you typically tag modes. I will not be covering this in this talk. I'll share a QR code with you. You can join us on a free WhatsApp group where we continuously discuss and practice how to tag modes. But the essence is that if you look at the tag column on the other side, that is how modes are named as if they were generic medicines. So medicines have a trade name and a generic name. paracetamol versus Calpol, Fepinil or whatever other names you have. Similarly, ventilator modes have names like that. PRVC, Autoflow, CND plus, whatever. That mode tag is the generic version of that. So for you to know what the mode is actually doing, you can't rely on the trade name. You have to rely on the generic name, which is the tag. This is something to identify before we go into all the steps that I listed. Be very clear that the term pressure control and flow control are distinct and based on the flow time and pressure time scalar. The scalar to look for is the one that has a geometric shape. And I'll repeat this throughout the talk so that you develop a sense of practice to go along how we classify modes. Remember, I'm using generic terms and not company-derived trade names. The equation of motion, some of you who are in training and others who are more on the respiratory physiology side will be familiar with this equation. Pressure on one side, resistance times flow and elastance times volume on the other side. These are two hands of the equation. Every microprocessor in the ventilator can only control one of those variables at any given time. It can either control pressure or flow. It cannot control both at the same time. And all the pieces of the equation are always visible to you on a ventilator screen. So the default ventilator screen you should maintain when you're in practice is actually these three. You don't need to waste screen space with a loop or any other information. What you actually need is a flow time, pressure time and volume time scalar. Three most important graphs because graphically that is the equation of motion. So I won't go into details of this because we covered that, but this is where I would like your attention so that you can train your eyes to recognize certain key patterns. You are looking at the load and if you are in volume control, what you will see is that typically the volume or the flow waveform will be a square wave. If your waveform is square wave, look at the pressure time scalar, and the pressure time scalar can show you three types of loads. One load is if the black is your standard, how you should see it on the textbook. If you see it like the red dotted line, that shows PMUS or patient effort is present. If you should see a step up and no change in slope, that's the green line. And if you see a change in slope, that is a compliance problem. You have to train yourself to see these patterns repeatedly, screen over screen. Similarly, if you are in pressure control, if you are in volume control and ramp, your waveforms will look as on the bottom part of the same slide. Now, if you are in pressure control, don't look at the pressure time much. Look at the flow time. So the flow time will change according to this graph. Last image here in this corner, this is your flow time. What happens is pressure waveform is fixed, so it will show a rectangular or a square shape. Therefore, the dependent variable, all the changes that I showed you in the previous slide, you need to train yourself to see on the flow time waveform. And we'll do practice on this. Similarly, on expiration, both in DC and PC, expiration is passive, so only one graph is enough for the template. And any trainee, anybody who is seasoned can use this for further classification. So moving on, the next thing is to look at the load and look at work shifting. So work shifting is another way of saying flow starvation, but technically flow starvation does not apply to pressure control. Pressure control means you can get any flow you want. So using the word flow starvation doesn't make sense. Flow starvation applies more to volume control. So in pressure control, look at the pattern in the middle part, flow time scalar. A passive patient will be an exponential decay. Little bit of effort will be convexity and a lot of shifting will show much more pronounced convexity. That convexity will have more than 50% of the area under the curve occupied by patient's effort. Again, something to keep in mind. Similarly, when you are in volume control, work shifting is noted not on the flow time but on the pressure time. So just train yourself. If you are in a pressure control mode, look at flow time. If you are in a volume control mode, look at pressure time. So now you are looking at pressure time. If the patient is completely passive, you are going to see a waveform like this, exactly like you would see in the textbook. If there is effort, effort is denoted by this red tracing. Red tracing shows the PMUS negative pressure inward. This is called flow starvation. But work shifting is the more broader term that applies to both modes. And severe is when that pressure line crosses the basis and it can cause lung injury by the way. So here's a practice session. What mode is this? Is it pressure control or volume control? There are no labels here. You just need to look at the waveform and guess. So it's pressure control. The pressure time scaler is roughly square wave. No confusion. Look at the pattern on flow. Decelerating pattern, exponential decay. I don't see any major problems. That's your pattern now. So this is an elastic load on pressure control. That's your load assessment. What's this? Is this pressure control or volume control? This is a Mindray ventilator, and on the Mindray it will tell you that it's volume control, but actually this is pressure control, which is why I said train yourself on the graph, not on the manufacturer derived mode. This is pressure control. What is the load? Again, think of the mental map. Just like you're reading X-rays or ECGs, it's a pattern. What's the pattern that you see? You see that the pressure is trying to go down, but it's not a very quick exponential decay. It's a slower decay. Slower decay means green dotted line. Green dotted line means resistive load. So that's in inspiration. Then go to expiration. In expiration, you see the same problem. It's not touching the baseline. It's generating some auto peak. Now, same ventilator, different mode, but you can see the pattern change. This was pressure control, this is volume control. Flow is fixed, pressure is a dependent variable. And again, if you look at the pattern, in expiration you have the same pattern where you have a slower decay. Green dotted line is your template pattern. Your patient matches that pattern, therefore this is expiratory and inspiratory resistance. Another practice one. What is this? Flow control or pressure control? Flow control. Doesn't matter what the mode says, this is flow control, flow is fixed. But look at it, there are a lot of secretions. This is a common secretion pattern, but again, practice. Remember we talked about the step up? The black step up means it should just be few centimeters of water and then it should transition to the linear increase in pressure. But see the step up here, it's pretty big. Right? It's that initial step up is very high, which means all the work that the ventilator is doing in the first few hundred milliseconds is to overcome resistance. So the resistance work is very high, therefore this load is called a resistive load in inspiration. So you can look at the consequences here. What we did for this patient is we removed the HME filter which was blocked, fairly easy fix. And this is what we show, that step up comes down. So your resistance has come down, but it's not gone away completely. This patient still has COPD. So look at the expiratory load, it's still not reaching the baseline quickly. Same thing, different ventilator. This is the GE Carescape 860. So in our network hospitals, we have about 250 hospitals. In our network, pretty much any ventilator that you know is somewhere there in our database. And you can see this is the problem. Again, this is high resistance, but there's one more abnormality here which we'll come to later. We'll talk about this abnormality when we talk about cycle problems. Now, moving on from resistance, what you see here, another pattern. This is pressure control. See the pressure time scaler in the bottom? Pressure is fixed, it's like a square top, so this is pressure control. But see how quickly the flow is decelerating and declining. The TI is set at 1 second. But the flow declines very quickly and there is a pause there for a long time. There is no airflow in that time, right here. So the pattern that best fits is the blue dotted line. This is an elastic load. Low compliance, high elastance. This is an elastic load. Again, train yourself. In pressure control, when you see a rapid decline in flow, reaching a baseline quickly, very short time constant, that's a compliance problem. So remember I told you how manufacturers can trick you. See the mode name here? It says volume control. This is not volume control. Absolutely not volume control. This is a Draeger ventilator. Draeger is notorious to do this. Keep a sharp set of eyes on the waveforms. This is pressure control. And this is what the pressure control waveform looks like. So just a memory jog for you guys post lunch. Square shape for pressure control. This is pressure. Even though the tag says DC. It's not DC. So we reduce the TI and the patient is a lot more comfortable. This patient is on a FiO2 of 45%, P per 5, recovering ARDS, still has stiff lungs, but I'm getting close to the liberation phase, so I don't need high peak, but I know that compliance is still low, and we showed how to look at the pattern. Now moving on to the next pattern. Look at this. This is another pressure control mode, but it's a little bit more complex to decipher, and so I've done some screen markings on this. This is how we analyze it on our WhatsApp group. But look, there's a convexity on the flow waveform. So the pressure is relatively stable. The ventilator is trying to control the pressure. It is a pressure control mode. But see, that red dotted line pattern is what you're seeing here. Instead of seeing a nice blue decelerating curve, we are seeing all that extra effort. The patient is putting in almost 60% of the work of breathing and only 40% is done by the ventilator. That extra work is patient effort. So if this patient, your goal in this patient is comfort, you are not keeping the patient comfortable because the patient is doing 60% work, ventilator is only doing 40%. So what you need to do here is actually increase the pressure. Another one, same ventilator, this is the Hamilton. On the Hamilton ventilator, look at it, this is flow control. However, in the middle, remember the pattern that I showed you earlier? The pressure is falling below the baseline. This can lead to patient self-induced lung injury, PCI. So if you see that big red flag, as an intensivist, anesthesiologist, act immediately. And you also see all that extreme work shifting. The waveform should have looked like the blue one. Remember the pattern. And we're immediately seeing that there is a lot of PMS, lot of patient effort here. So here you need to see, is there acidosis, is there severe sepsis, anything increasing the demand that is required for ventilation. And you can see all these features on a single snapshot. And this comes with practice. Here's another one. Similar type of patient, see the convex waveform on the flow time scaler. This is again the pressure control waveform. Look at the bottom. The pressure support that set is 2. So, unless you're trying to really test the patient for something in particular, maybe a marathon, this is not a great setting. Because what this is showing is almost 80% of the work of breathing is done by the patient. I've shaded that. So your area under the curve for the flow time waveform actually shows you how much work the patient is doing on pressure control. And you can see that essentially the patient is breathing mostly on CPAP. The PS is not doing anything for the patient. So a pattern to keep in mind. So now we'll go and look at other abnormalities. Just a second. Yeah. So we finished resistance, compliance and PMS related loads. This is to look at trigger patterns. There are 4 trigger patterns: late, early, false and fail. So what you see here is pretty straightforward. This is a missed or a failed trigger where there was a deflection and the ventilator did not follow it up with a breath. Very simple and straightforward to detect, not a complex problem. Easy to solve by changing the settings, either a flow trigger may be helpful or increasing the peak may be helpful. Next, what you go on to see is something called reverse trigger or early trigger. Early trigger is defined as when the ventilator gives the breath before the patient wants the breath. And that's what we are seeing here. The ventilator is already pressurized and then after some time the patient's effort comes and increases the flow. That's what we are seeing. This is not a double trigger. It can lead to a double trigger, but this is early trigger or reverse trigger. Other trigger problems are, all of these are double trigger, and frequently in exams I see this error. People just call it double triggering or double stacking. Double stacking or double triggering is an observation. There is an underlying abnormality that you need to define. Just like fever is not a diagnosis. So these are the 3 different types of things that you see. One is due to early trigger, where the ventilator started the breath before the patient's neural eye time caught up. The other one is a false trigger, where there is no signal from the patient. And the last one is early cycle. The ventilator is cycling off before the patient is ready to cycle off. So the patient's neural eye time is much longer than the mechanical inspiratory time. And that's when you can see a double trigger. So do not accept double trigger as an answer. See what the underlying abnormality is. Moving on to cycle. Remember, this is rapid fire, so we will move on quickly. Cycle means what is turning the inspiration off. And the abnormalities are normal, late and early. And these are the classic patterns. So here, again, look at the pattern. This is what a ventilator looks like when it's early cycling. This is a brand new ventilator in the market. It's called the Noka ventilator. Some of you during COVID would have seen this. This is the ventilator project product. And you can see that the expiratory time, the expiratory trigger is at 30 seconds, 30%. We changed it, and now the early cycle is gone away. So the patient has enough time to actually take the breath. We just changed the criteria for cycle. This is what is known as late cycle. The patient has already finished the breath and is trying to exhale, causing the pressure to go up, but the TI is too long. So to solve this, you just need to shorten the TI. So this is a late cycle. Same pattern. Again, it's all about pattern recognition. This is a harder one. I'll leave this for the last, and at the end of this, we're done. This is your Mackay servo ventilator, and you can see multiple abnormalities here, and I've labeled all of them. This is how you'll have to practice. What you see here is that there's not much of a step up, so it's not a resistance problem. Peak expiratory flow is high only on some breaths, not on all breaths. The red arrow is showing late cycle. The patient wants to breathe out, so the pressure goes up. And what's happening here is it looks like there may be a leak by the orange arrow, but actually there's no leak. What's happening here is that in some of the breaths, the patient has a desire to breathe out, not in all breaths. So in the breaths that the patient is breathing out, you see a higher expiratory flow. I've shown it by the magenta line, it's crossing the blue line. And when the expiratory flow is high, the patient exhales a lot more. And you can see that discrepancy. 398 tidal volume went in, 369 came out. That happened in the last breath. So you can see that even the slope is changing. Here the compliance is high, and here the compliance is lower because the lungs are more full. And each of these abnormalities you can train yourself to see on successive waveforms. Some of them are easy, some of them will take practice. So by practice I mean you can log on to this. It's a continuous session, it's free, you can join. And what we do is you can share cases on this WhatsApp group, and we'll discuss those cases going through the same thing: tag, load, PV, relationships, and then arrive at a diagnosis. So hopefully this was a trigger to start a practice session for how to analyze ventilator waveforms. I thank the organizers of the Gujarat ISA. Thank you very much, happy to be here. Looking forward to the next time.
Thank you very much, Dr. Dileep Raman. I would like to invite Dr. Dileep Raman to felicitate Dr. Raman.